And then the last expert we have is Dr. Yvan Beaussant. Dr. Beaussant is instructor of medicine at Harvard Medical School, instructor of psychosocial oncology and palliative care at Dana-Farber Cancer Institute. Welcome.
Thank you very much. Thank you for this invitation. It's an honor to be invited. A lot has been said already, and I think I will just add some considerations around the patient population that I take care of, people with serious illness and at the end of life. As you mentioned, I'm a palliative care physician. I was trained as a hematologist and palliative care physician in France. I moved to Boston 7 years ago to start a research fellowship in psychosocial oncology and palliative care at Dana-Farber Cancer Institute to focus my research on psychedelic assisted therapy and their potential roles for to alleviate psychological and existential suffering in people with serious illness and at the end of life. So a few points, and maybe I would like to start by telling a little bit about the patients with cancer and patients with serious illness experience and symptom burden. We know that psychological and existential distress is common in this patient population and typically more frequent than in the general population. People will have 2 to 3 times the rate of depression than in the general population. They will very frequently experience existential distress, which corresponds to death anxiety and demoralization. Demoralization is a syndrome that where people experience loss of meaning and purpose, hopelessness, helplessness in the face of a life-threatening illness. And we recently did a study at Dana-Farber in the outpatient palliative care population. We found that 43% of our patients qualify for moderate to severe demoralization, a clinically significant intensity of this syndrome. 25% qualify for major depressive disorder, 14% with general anxiety. So these are altogether, it's a big proportion of our patients who have unmet clinical needs in terms of their psychological, emotional, and spiritual experience. At Dana-Farber, we are fortunate to have a state-of-the-art model of psychological and spiritual care, and despite that, we see those unaddressed needs. So that's really a way to emphasize that we haven't had, so palliative care have been evolving over the past 2 decades and have really shifted the way we take care of patients in a more integrated and holistic way. And nevertheless, we failed to address the most commonly experienced psychological and existential distress from our patients. So shifting gears and telling about what drew my interest in this field of psychedelic assisted therapy. So there, and a lot of what compelled me to focus my research comes from the research conducted by Professor Johnson, who we just heard, at Johns Hopkins University and at New York University, conducted very important studies of psilocybin-assisted therapy in patients with cancer. These were published in 2016. They comprised not very large number of patients. These were like 51 patients and 29 patients respectively, but these were conducted in a very rigorous method. So and the results showed unprecedented findings on how people responded to psychological, to psilocybin in terms of their psychological and existential distress. 80% of them had a response on their depression. 50% were no longer qualifying for depression at 6 months after 1 dose of psilocybin-assisted therapy, which is not something that we see at all in any behavioral intervention in cancer care. And so the response were impacting levels of depression, anxiety, spiritual well-being, existential distress. Most patients would qualify the experience as among the most spiritually significant in their lives. And what this research found as well is that the subjective quality of the experience. So there is a pharmacological action of psychedelic-assisted therapy, but there is also the experience that also explain the results. And one of these phenomena is qualified as mystical experience, so people having strong spiritual experiences from which they can derive meaning and relief, and find relief in death anxiety and depression and anxiety. There was no serious adverse event reported in any of these studies conducted with cancer patients, meaning that no people were hospitalized or died because of psilocybin. And the adverse events were those that Matt Johnson reminded were mild and transient, like nausea and headaches, and mild elevation of blood pressure and heart rate. So maybe also important to emphasize that in this medical model, we really see this as both a pharmacological and behavioral intervention. It's not just a classic drug model where you give a drug to someone and expect to see the outcomes. It's really a psychosocial intervention with a number of hours of preparation, of counseling for preparation, guidance through the experience of mild altered consciousness, and also a number of hours of counseling after to make sense of the experience and see how it can integrate into people's life. I think, to me, that's one question about the legalizing or other models is what will be the amount of psychosocial support that may be required in some patients to prepare, accompany, and integrate the experience. And one of the reasons is that we've mentioned the potential of challenging experiences that people may encounter. This can also be very profound experiences that may change the way people see the relationship to themselves or to the world, and that really can deserve a lot of time for integration in a thoughtful way and supportive way. One of the studies that we conducted recently in patients with cancer was focusing on acceptability of this experience. And for people, what came as very important was, first, they highlighted how intense and demanding the experience was. So something to consider also for people at the end of life who are vulnerable, may have physical symptoms, may be fatigued, etc. It is an intense and demanding experience, psychologically, physically, spiritually. They described a tension going through the experience between surrendering to the effect of the drug and also resisting, like a natural incline to resist. So a whole lot of the preparation is to prepare patients negotiating this tension between resistance and surrender to the effect. And then they also described a sense of being vulnerable and suggestible and dependent toward the setting and especially the people around. So echoing what Professor Johnson said about the potential for abuse as well, and the importance of very strong ethical boundaries in guiding these experiences. So that's really to tell about the background of the research. And so we at Dana-Farber have started a research program to further the science of psychedelic-assisted therapy in patients with cancer and at the end of life. There is, as Dr. King said, there is 40, 50 years of research gap that we need to fill to understand better how they work, for whom they work, according to which therapeutic modalities, which drugs, and what are the therapeutic outcomes, what is the safety. So I think there is, in the medical model and as things unfold in the community, there really is a need for research that is very strong. there is a need for education as well, and there is a need to learn about how do we integrate those treatment modalities into our existing treatment delivery models, and what are the coordinations between the oncologist, the palliative care clinician, and the people who will provide this therapy to make sure that there is a coordinated care for people. Right, so I'll just conclude by just re-emphasizing maybe the need for screening as well. I think I want to advocate for people with the serious illness, given all the clinical need and the therapeutic potential that I described. I think it is essential to provide better access. Every week we have dozens of requests from patients that we cannot provide these treatment modalities despite their needs. And yet it's very important to also consider their vulnerability and the importance of screening to make sure that they can have these experiences in a safe condition. Thank you. Happy to answer questions.
Thank you. Questions? Are there barriers? Are there state barriers to your research?
So it is. I mean, we've been able to. We just finished enrollment of the first trial of psilocybin acid therapy in patients who receive hospice care. We worked with Care Dimensions Hospice, and we're able to treat 10 patients who receive hospice care. So this requires approvals from the IRB, of course, the FDA, and that won't change, and also the DEA, because it's a Schedule I license that adds some layers of regulatory hurdles. I wouldn't say there are barriers. I think the main barriers is around regulatory and funding, to really, I think, emphasize the clinical need. Right.
Okay. Thank you. Any questions?
I heard you reference the need for research several times. Do you think that there is we have enough research to move forward with the proposal here, or would you be more comfortable if we waited until there was more research?
I think that's a good question. I think Dr. King mentioned some of the naturalistic research that we have that emphasize the relative safety and potential benefit when it's used responsibly in the community. I think, and I believe in implementation research, or action research that is being conducted. So I do believe that it's important to monitor what is being done and the effect, and to be flexible so right, that would be more my response.
Thank you.
Thank you very much.
Okay, thank you very much for your time, for testifying before us.